Hi, I'm Jennifer Marquez, and this is my concept application project for healthcare delivery. Microsystems of the ICU is what we're going to be talking about today. And what are the goals of the microsystem in the ICU? We have a multidisciplinary approach. We have patient family-centered care. We're a closed intensivist-led team, and the nurse-coordinated patient care. Multidisciplinary approach means that many different clinicians from all areas of the hospital are coming together to provide care for the patient. A patient family-centered care is ICU is unique in that many times the patient is unable to express the needs and families are often making important decisions. We're a closed unit because the intensivist takes over for the primary care physician or hospitalist when the patient arrives to the unit. The nurse coordinated patient care is led by the interdisciplinary rounding, and she's in charge of evaluation of the treatment plan and adjusting and coordinating as needed. Leadership goals in the ICU would be that they encourage staff development, they stimulate motivation, they have a team-based approach, and they have a level of emotional intelligence. Also that they support job satisfaction. Spano, Zeekley, and Quinn Griffin explain emotional intelligence and transformational leadership, and we'll build on that for this slide. By encouraging and acknowledgement of staff for teamwork stimulates job satisfaction. We have these caring hearts in our unit, and we give them out when a team member has done an excellent job. Leaders are expected to provide feedback from daily rounding. Was the family and physician happy with the nurse's care? This kind of encouragement and feedback can be used to better our practice and give you a boost when you've done well. Provides valuable feedback to learn what we could have done better. The leaders are expected to be involved in daily and shift rounding, evaluation of the care completed, and putting the right nurse with the right patient. Was infection control practiced? What went well over the last 24 hours, and what can we can we change? They also are responsible for managing conflict, and by utilizing the team to find resolution. They work to involve staff to find innovative solutions to conflicts through meetings and committees. They also provide a voice for the microsystem to the macrosystem. Through meetings and speaking with staff leaders, they are responsible for improvement across the microsystem. How does the organization meet the goals? How does the organization support the microsystem of the ICU? With clear expectations, good work experience, organizational workings, and organizational learning. The organization provides clear expectations and goals for our ICU patient population. Decreasing hospital-acquired infection rates. Due to the nature of the ICU, our patients are at a higher risk for infection because of invasive procedures and equipment. The organization can identify staff who needs improvement and ongoing education and sessions to keep up the skills level and practice procedures. Organization wants to improve on patient and staff experiences. How can we improve this critical time in a patient's and family's life? How can we keep staff engaged and prevent burnout? By including patients and families in the plan of care and interdisciplinary rounding, clear patient and staff goals daily. In our facility, we round at 9 a.m. daily, and this includes the nurse manager, charge nurse, primary nurse, intensivist, pharmacist, nutritionist, case managers, and any consulting physicians and family. May also include advanced illness management and the chaplain for end-of-life care. For staff experiences, consistent evaluation of what is working and what is not working in the unit. Listen to your workers, listen to what's going on out there, fix problems with your nurses and workflow issues. The organization is working across the organization by implementing policies and procedures and also ensures that they are updated as needed. It is important to keep up with the latest evidence-based practice like the newest sepsis bundles. Hospital-wide education and the latest technological and procedural practices can help improve patient outcomes. It is important for other microsystems within the organization to be learning to identify sepsis patients and recognizing the need for a higher level of acute care. Rapid response teams, sepsis and cardiac activation, stroke teams, and code teams are all used to provide quick assessments and interventions, but these practices will not be effective without organizational-wide learning activities. The culture of the organization includes what is important to the organization, how can we meet the values and the mission of the organization. Patient and family-centered care in the ICU. We have a holistic approach. We encourage patient engagement, and we try to ask ourselves, how can the ICU team maintain patient and family-centered care? How can we improve upon staff improvement? Holistic approach is what we do as nurses. We look at the whole patient, all their medical conditions, each body system dependent on one another, the patient's cultural beliefs, their fears, expectations. providing them with education, resources, and support for in the hospital and beyond. Acceptance of what the patient wants and needs, and making that the focus. Does the patient want everything done to save their lives, and making sure that they are aware what everything means exactly. There have been times in practice where patient and families agree that they may not want extensive life-saving surgery, and we as caregivers are there to give them the best care that they can get and fully inform them of the outcomes. Other times we may feel the patient is at end of life and quality matters, not quantity, but that is made their decision as well and is their choice that they need to make. As nurses, we are consistently working to improve our care, improve our practice, improve our education. Nursing is constantly changing. As staff, we must have a high level of open-mindedness for opportunities. Our organization offers many educational opportunities throughout the year. Last year, our unit was invited to a large cardiology conference, a CCRN review, advanced EKG training, and in-hospital practices monthly on different code situations in the hospital, all to improve staff, which in turn improves patients' outcomes. Interdependence of the care team. Relationships are built on trust. Patient and family trust of the care team, trusting your fellow nurses, and physician and nurse trust. Rena and Rushton brilliantly describe the trusting relationships of collaborative team in their article, Trust, the Foundation for Team Collaboration and Healthy Work Environments. Patients and families must find a level of trust for the doctor and nurses. They trust us to be up on the latest approach to care and the latest advanced medications and practices to provide the best care for them. In the ICU, you have to be able to trust the nurse who will be at your side during intense situations. We rely heavily on one another in life or death situations. If you can't trust your fellow nurses to help you care for a patient in trouble, you can find yourself overwhelmed and in a bad situation. You must also be able to point out things that went wrong and what needs improved upon, as well as what went well with any particular situation. Having the ability to accept criticism and feedback is all part of being a good team member. As nurses, our whole profession depends on trust. Nurses and doctors in the intensive care require a high level of trust. We must trust them in making the best care decisions, and they trust us to fulfill their plan of care, and each dependent upon one another. This level of trust fosters a unique relationship that the nurse can act autonomously and question things that may not be right for the patient. We are held to a different level of trust in that the doctors trust us to recognize complications or deteriorations in a patient and act accordingly. As nurses, we are at the bedside 24 hours a day, and a trusting relationship is a necessity. The use of information in healthcare technology. We use electronic medical records and the newest technological equipment. The ease of shared information, we have a high-level patient monitoring system, and we have life-saving medical equipment and procedures. EMR, CPOE, and practice partners improved healthcare and shared information tenfold. The ease of transfer of health information continues to improve patient-centered care and decrease medical expenses for the patient and the organization. In the ICU, we have many of the newest monitoring systems such as Space Labs, bedside monitoring. We can closely monitor every second of the patient's stay in the ICU and see the information at the bedside, nurse's station, and the hallways. We can see many hemodynamic parameters continually and set alarms based on the goal of the patient as an individual. With the use of health information technology, our patient's hemodynamic parameters are transferred seamlessly from the bedside to the chart. This information can easily be seen across disciplinaries to coordinate a patient-specific plan of care. With technologies like hypothermic protocol and Arctic Sun, post-cardiac arrest mortality rates are improving. We are giving our patients a fighting chance in an otherwise losing battle. Like many other ICUs, we've also started utilizing less invasive monitoring systems for monitoring cardiac output, stroke volume, systemic vascular resistance, and oximetry levels, with the use of transduced fiber optic central line and arterial line in the management of patients with severe sepsis and septic shock. Process for healthcare delivery improvement. We have an ICU committee, and we use clinical nurse specialists to improve upon. The committee meetings are monthly with the intensivist, nurse manager, clinical nurse specialist, leaders of the ICU, and organizational leaders, quality assurance nurses, and infection control. Come together and evaluate specific patient outcomes and provide accountability of doctors, nurses, and the organization based on performance levels. Was the core measure followed? Were all treatment options explored? Also finding weak spots in policies and procedures. Currently, we are meeting about sepsis and improving this patient population. Did a repeat lactic acid get missed? where the bundles followed and feedback with rationale explored. With the integration of a CNS, performance levels and practices are improved upon. Our care has improved. Our CNS can evaluate how we are preventing VAP by monitoring nurses and RTs. And she is also evaluating our code blues. How are we doing on compressions, meds, ACLS guidelines? By watching the process, she makes adjustments and provides practice and learning opportunities to better our skills and improve our outcomes. Staff evaluation, we use a process review and a multi-source feedback, and we also have a rating system. In the ICU, we have 4 levels of multi-source feedback: the manager, physicians, the team, and self. Our performance on communication includes with the patients, families, physician, and team members. Is the nurse proactive and effectively communicates the needs and values of the patient? She's reviewed through patient experiences and interactions. Are communications clear? Does the nurse paint a clear, concise picture of what's happening with a specific patient? Is there need for extra education? Does the team member get involved and excited about new technologies or the latest treatments? Are they involved with improving protocols or the designing of protocols to improve workflow or outcomes? Is the team member someone you can trust? Are they a team player? Do they answer other call lights? Do they check IVs that are beeping? Do they assist different family members? And can be as complex as if they're there, you can count on them when you're in a code situation. Each of these are equally important to the care in the ICU. Evaluations in our unit are based on a number scale 1 to 4, including 1 not meeting goals up to 4 excellent achievements. Can we improve current healthcare technologies? And this may eventually lead to improved workflow for nurses, faster, accurate care for patients, and improvement of the CPOE programs. While the electronic medical charting computer program has improved patient safety, the program used is not user-friendly and as it should be. This causes some frustration among care providers. Lab tests and other results are jumbled up, and if you're not careful, you could be looking at the result from days ago and not the most recent. The computer program could work with EMR to improve upon intake and output for patients, including when you hang a bag of medication, the fluid would upload to the patient's chart based on the rate and amount prescribed. Changes need to happen quickly to improve upon screens or tabs within the charting. Currently, to make changes in the program, it takes months, and this is not user-friendly to nurses. With improvements, we'll be able to share education with patients from the bedside with the click of a button. Currently, it takes some navigation around 3 different systems to address specific needs of the patient. CPOE, when it's working, the physician can find the medication and dosage he or she is looking for, cuts workflow in half. The problem is if the medication or treatment is not built into the program, there's no way to order it in the proper way, so doctors turn to a paper handwritten order. This in turn can cause a multitude of problems, including an order that never gets processed, treatment not completed, or treatment that's completed late. Another problem is if the doctor slips the order in the chart without going over it with the nurse, and when she sees it, realizes it's illegible and the treatment is once again delayed. So how do we lead the path for improvement? So we need to utilize nurses who are proficient with computers. We need to encourage the health information technology specialists to make monthly rounds and to find out what is working and what is not. They need to be able to make changes to the program quickly. They need to meet with the program design specialist periodically. A detailed plan includes search out nurses that are proficient with computers and advanced technologies and build a team of nurses to make rounds on staff nurses to hear their requests and to find out what is working and what is not, or what they may need from the system. As healthcare is always growing and evolving, our technology must not get stagnant. Get the physicians away from writing any orders and provide special attention to physicians who feel that there may be no other choice. Find the root cause and work quickly to fix the problems within the systems. Meetings with the program design specialist will only bring about changes when they identify problems in workflow. If the bedside nurses have a place at these meetings, they can meet until they are blue in the face. It won't matter if they are not there, the ones utilizing the software day in and day out. In conclusion, healthcare is a complex system with many moving parts, but if we tackle specific areas for improvement, we can consistently grow and improve outcomes and staff satisfaction.